sevgili hocamızı size tanıtmak istiyorum. Doçent Doktor Milka Pejović Milanković Milovankević. Kendisi Sırbistan'dan geliyor. Belgrad Üniversitesi'nde Çocuk ve Ergen Psikiyatri Kliniği'nin bölüm başkanı. Bir yataklı bir klinikleri var ve orayla ilgili, o klinikle ilgili bugün bize ayrıntılı bilgi verecek. Aynı zamanda ESKAP üyesi kendisi ve çok uzun süredir özellikle gelişimsel bozukluğu olan çocukların tanı ve tedavisiyle ilgilenmekte. Çok teşekkür ediyoruz bugünkü katılım için. We thank to her for this contribution. She is an associate professor of child and adolescent psychiatry, and I invite her to the...
Hello, good morning. Thank you very much for your kind invitation, and let me first thank you, Gul, and thank Professor Fusun Çuhardaroglu because she was always supportive and toward our association, and as I told you this morning, I hope this is just beginning of our future collaboration because I think we share so much in common, like even phenotype is the same. Yeah, thank you. I was asked to talk about services in China adolescent psychiatry, and I'm very pleased to be in this imperial city. This is, in my opinion, one of the loveliest cities in the world, and you don't know how you are lucky that you have a city as Istanbul. It's really something that is moving and always is something living here. So. As Gul told you, I'm coming from the Institute of Mental Health, which is one of the leading institutions in child psychiatry in the region. I'm also associate professor at University of Belgrade School of Medicine. Why I'm telling this again? Because last night I heard that you have at the University Department for Child Adolescent Psychiatry. Unfortunately, we still do not have department. I'm the only one child psychiatrist working within the Department of Psychiatry. So we are still do not have recognized within the university child psychiatry as a special program, but we have a residential and training program. So today I will talk about epidemiology. So I want briefly to tell and to share with you experience why we need good child and adolescent mental health services, which we are in Serbia lacking, and I heard last night that also you have much more needs than you have services. I will also tell you something generally about principles, how to establish and what are the good examples and good child adolescent mental health services. Then I will tell the models of community-based care, which we think for the societies like ours, where you have more than 25% of the population less than 18, and then it's pretty much same in Serbia as well. And in the lack number of the child psychiatrists and services, what we can do and how we can organize the community-based services. Then I will present you some data regarding the services in European Union, and the last part and the largest part of my presentation will be about services in Serbia, and especially the clinic where I work, so we can share some experience, and I'll be more than happy to respond on your questions or comments if you have in the end. So we all know that we have high prevalence of mental health problems among children, adolescents, and young adults. There are some estimations that around 20% of the children and adolescents have some mental health problems. Unfortunately, only 10% of them are recognized and are treated within the child and adolescent mental health services. It's also very important, and I always use my opportunity whenever I'm talking in front of the adult psychiatrists. We are here, child psychiatrists, for we understand each other well, but that half of the lifetime cases of mental illness are now recognized to begin before age 14 and 3/4 by age of 24. So what we need is a better collaboration on one side with the pediatrician, who are probably the first one to see patients here and all around the world. However, we also need much more better communication with the adult psychiatry, because I don't know how it's here, but in Serbia and in the region, because I can speak about the region countries as well, Slovenia, Croatia, Bosnia and Herzegovina, Macedonia, we all suffer from somehow of neglect of adult psychiatrists, because they assume us very childish, and that issues that we are covering, they are thinking it's not so important, and their issue, I don't know how it's in Turkey, but this is something that's happened in my country. So the median number of years from the time a child first experienced psychiatric disturbances and received treatments is almost 10 years, according to some research about 9 years, and only for psychotic illness is less than 9 years, which is 2 years, probably due to the clinical signs. So we have a huge problems in recognition and treatment of the child and adolescent health issue. Despite effective treatments, however, there are typically in almost all countries some long delays between the individuals first experience clinically significant symptoms and then first seek and receive treatment. As I told you, 10% of the children with mental health problems receive any kind of help. So this is the picture that I took from the WHO association, and it's about dailies in 2000, attributable to selected causes by sex and age. And as you can see, when we are speaking about neuropsychiatric conditions, including self-inflicted injuries, we have large proportion of the children and adolescents, and this is something that we need when we compare, for example, with malignant neoplasms and cardiovascular disease. You can see in the almost more than 25% of dailies in this specific age group are due to the neuropsychiatric conditions. And this is something that all are aware, but still we do not have sufficient help to this particular age group. So severe, for example, when we are talking about depression, which is one of the most common problem, for example, in adolescent, we can have that maybe 17% of the adolescents have depression, and still it's almost every fifth of them, and still we are lacking in giving them opportunity to help and to improve their condition. Then when we are speaking about anxiety, this is something that we even yesterday talked about anxiety disorder, which we know that is one of the most common disorders in the children and adolescents, and we don't even have a sufficient research about the anxiety globally, not talking about only our region. We don't have a guidelines, for example, for anxiety, and we have thousands of them on ADHD or autism spectrum disorder, which of course they are important conditions, but comparing with the prevalence of, let's say, depression or anxiety, these two things I can say it's neglect. So we need, when we are speaking about services, to take into account not only psychosis and ADHD and autism spectrum disorder, but we need to think about depression, anxiety as one of the most prevalent conditions in child psychiatry. Also, I don't know how is the situation in Turkey, but in Serbia we have increased number of youngsters who are start using illicit drugs. So, and we don't have any institution, or we don't have even professionals who are educated to give a help for the patients below 15, because we have now cases of children below 15 who are starting using drugs since 12 or 13, and none of us are educated to give this kind of special help. So we are really lacking of infos, we are really lacking of epidemiological studies, we are facing problems how to help children who are using substance, and this is the increasing problem. Also, when we are speaking about suicide, the most feared and tragic outcome of the mental illness, our youngest patient who committed the suicide was 8, and it was due to the depression, and depression was not recognized. So this is, and we all are aware that this is the 3rd most common cause of death among adolescents and young adults, preceded by a car accident mostly and homicide. So again, this is the huge issue, and our services need to be aware of this. What is also very important, and we are kind of trying to improve our collaboration with the pediatrician. We don't have well-developed liaison child psychiatry, and I heard yesterday that most of your departments are within the pediatrician setting, which is okay. Comparing, for example, the countries where, and the region where I am coming from, we are have separate clinics for, let's say, adult psychiatry, and within the adult psychiatry we have clinic for children and adolescents. Also in many other institutions, which I will show you later, we have this kind of thing. And then when you have large university pediatrician hospitals with more than 500 beds, you don't have any child mental health professional, except maybe 1 or 2 psychologists for such a large number of kids. And we know that children with a chronic illness are 2 times more likely to have psychosocial dysfunction. And vice versa, children with the mental health problems, they have higher users of health care due to their physical conditions. So we need to get and to improve our collaboration. And this is something that I really found very useful to share with you, that by 2020 or 2030, it is estimated that up to 40% of patient visits to pediatrician will involve long-term chronic disease management or physical or psychological and biological condition. And this is something that Pediatrician Association has as a goal of their task force for the vision of pediatrician up to 2020. So they believe that in 2020 pediatricians have a wider array of skills, including more in-depth knowledge of comfort treating, behavioral, developmental, and mental health concerns. Medical education should include mental health intervention, which are now, and I don't know what is the position in Turkey, so I would really like to know, like since 2016, like very recently, pediatrician in my country start to have education about developmental problems and mental health problems, but it's because it was completely neglected by them, all these kind of issues. So when we are speaking how much patients are getting help, unfortunately, we don't have numbers from most of the country, just because there is a lacking number of child psychiatrists, and when you need to do everything like research, clinic, studies, it's just difficult to find a balance within all of these issues. So we have data from abroad, and we know that we have increased number of children, and for example in US 15 million children have diagnosable psychiatric and learning disorder, but 70% of them don't receive help as they need. So can you then imagine if we compare such a developed country with underdeveloped or developing countries. So even if the country like US, they have a imbalance between the minorities, for example, you can see then 1 in 3 Caucasian kids with mental health problems got the help. But then you can see in African American or even Latino, they even, so these are imbalance between the minorities and between rural and urban surroundings. And I will speak about this a little bit later. So epidemiology is important to discuss, but still etiology is vital. Why say this? Because we are living in specific time of when you have large number of refugees in your country, as we have, and we need to face this kind of psychosocial troubles that they are facing every day, and we have this such a shifting from culture to culture, and it's going to, and the number of this kind of problems that we are facing is increasing every month. So it is tremendous burden of all of us how to organize service and how to help all needing. So on the one side. On the other side, if we want to help, we need to understand what's going on. So basic research and clinical investigation is needed to be and to face in order to understand the basis of mental illness. And then the tragedy is that we most often do not know the best treatment, and for whom various treatments will be most accurately provided. So somehow, sometimes I feel as a jongleur, you know what is jongleur? So on one side you have a family, school, center for social works, different cultural backgrounds, lacking in some even treatment procedure. Most of the medication in child and adolescent psychiatry are off-label, and you need to explain parents, expel patients why you are giving off-label medication to their child. So I guess we are or have a similar problem. So it's really very difficult to balance all these things. The growth in evidence-based treatment, including medication and psychotherapies, increasingly allow us to treat specific symptoms, but still in the country like ours, I mean, you are much more developed than comparing with Serbia, but in lacking number, it's really difficult to replicable fashion that we have from US or from UK. For example, we have in European Union, you know that we have only 6 or 7 medicines, like the treatment that you can offer, medical treatment that you can offer. So it's really difficult. So how this, comparing with all this that I already said, so how we can organize what will be the best services. Yes, I will. So I told about the lacking number. So what are the general principles about services in child and adolescent psychiatry? We are all aware that there are multiple inequities in the mental health resources available to rural and remote communities compared with the metropolitan areas. So basically, child adolescent mental health services are settled in the cities, and I think it's all around. And we know that most of our patients are also coming from the rural. So we always, whenever we have a child, we have a family as well. So separation with the families is something that we need to think about, and that's the reason why we need to improve more community-based services to come to the patients where they live, not to expect them to come to the cities and to get the best help. So triage assessment tools has been proven beneficial in assisting professionals in determination, prioritization, and assessment of risk for children and youth mental health problems. And just this morning, Gul and I was discussing how many patients she has per day in her clinic, and also is in my clinic. We are lacking a number of child psychiatrists, and the needs are increasing every day. And then somehow we need to improve the triage, because it's really not necessary to treat enuresis in the 3rd psychiatric department, university, child adolescent department. They can do by the pediatrician, but unfortunately pediatricians are referring to us even anuresis and even some kind of eating problems in 2 years old kids, which is, okay, could be some infant anorexia, but still they can do more, we can just be helpful to them. So triage is something that we need for services development. Also, community is much preferred by patient over hospital care. Imagine how difficult it is for children and for adolescents to separate and to get to the hospital. Of course, when it's need, but this should be the last thing that we should offer. Randomized control studies comparing community-based with hospital care for patients with severe mental illness who present for acute treatments as opposed to longer-term care have shown no advantages for hospital-based services in terms of clinical symptoms and social function outcome. So definitely we need to improve this kind of community-based care. Also, lengths of stay for psychiatric hospitalization for children and adolescents have shortened over the past 2 decades. For example, in the department when I'm working, we have now 16 days average stay, and then like 10 years ago it was almost 21 or even more than 21. So even that we have this kind of shortened over the past 2 decades, hospital-based care continues to constitute a major segment of youth services. The focus of psychiatric hospitalization has now shifted from comprehensive evaluation and treatment to brief intervention and intensive intervention, and this is something that we need to improve, that how we can actually improve and shorten the diagnostic procedure because it is better for our small patients and for adolescents not to be separated for long for their everyday life, for schools, from families. So this is kind of shift that is moved all around the globe. So more research is needed to improve our understanding of acute mental health care for youth, so that new strategies and policies can enhance the system of providing mental health services to children and adolescents. Again, I think we need to improve psychiatric consultation and liaison, which demonstrate in some country where it's working very well, improved efficacy of services delivery and cost reduction, but because it's less expensive. And I think our governments needs to know why we need to have mental health professionals, child psychiatrists within the pediatric institution. And I know it's like that, but in Serbia we are separate, and I think we need to improve this. And also something that I think need to be improved is home-based acute care treatment, which we don't have in Serbia, but there are in some countries they have this kind of treatment, because it is cost-effective, reduce loss to follow-up, decrease family strain, and results in greater community satisfaction. So we need to organize services to have more this kind of home-based acute care treatment, like making some mobile teams or making some more mobile child psychiatry services. The rates and the use of aftercare services evidences of their effectiveness has not been well documented, so we don't know, and we don't have a critical examination what is the aftercare services, because probably we have only time to in-service care, but this is something that we really need to know. And now I will show you later the paper which was published this year in ACAP journal about the follow-up, the transition from adolescent to adult psychiatry. So the emergency department is often the first healthcare setting to view manifestation of mental health problems in youth, and we need to improve the knowledge of the people who are working in emergency department. And they use often the direct result of inadequate availability of outpatient services in the communities. So if we develop more services in community, then we will have less number who are coming to the emergency departments. We need routine standardized screening for mental health conditions in children, which is lacking. Now we have improved the screening for early developmental disorders, so we now have MCHAT and those kind of interviews for really early signs. But then when we are coming to the adolescents or kids below 8, 10 or 12, we don't have good screening instruments. We need specific intervention to increase coordination between emergency department and larger mental health system. And it is imperative to consult users of psychiatric services like family members and young people and to involve them. Like in the department where I work, we have this small questionnaire which at the end of the treatment we give to our patients, and like mostly are satisfied, but there are some who are not, and usually they complain about time they spend in a direct contact with the medical doctors, with the physicians, because all of us are involved in many things. So even if we hospitalize patients, we are not giving them sufficient time to talk with us. And of course, when they are hospitalized, they expect be more with their doctors. However, we decide, and we have our allies like psychologists, special educators, logopeds, defectologists, and they are and even specialized nurses who are actually more involved in this taking care of inpatient patients. So if inpatient units survive, because we are globally have infos that they will decrease, it will be necessary to demonstrate what they offer over and above community-based care and why they're an essential part of child mental health provision. So I think we need to improve our inpatient services in that manner. So several models of community-based care that I generated empirically support are wraparound therapeutic foster care, intensive case management, crisis response, and day treatment. And later I will just briefly show how they can be organized. So, outcome research of residential treatment in child psychiatry can be plagued by methodological limitations and lack of funding. So we need more studies to show that how we can improve our work. Psychiatric hospitalization for children and adolescents has significantly shortened over decades. However, we have this kind of offering still. So when I told you about the models of community-based care, there are 6 models which I want to share with you now, and they are kind of new models of how the services in child psychiatry should be organized. So when we are speaking about wraparound approach, it is kind of unique set of community services and natural supports individualized for that child, for that specific child, and for the family. And this approach, individualized and strengthened-based services, they are working in family empowerment, cultural competence, unconditional care, and achievements of outcome. This is the use of flexible funding, which is also very important, and they emphasize on non-traditional services such as in-home providers, respite care, therapeutic foster care, and services provided by paraprofessionals. So somehow we need to involve them, especially when we are lacking of the specialists and when we have this kind of transitional periods. The other thing is intensive case management, which is effective for crisis-prone, high-risk youth population. This is the family-centered intensive case management, and they have it was developed by Evans, and this approach used parent-advocated and flexible funding to purchase economic and social support. And this is something that we are planning to start regarding the autism spectrum disorder, because we are all aware that these kids need much more treatment that we can offer in our institution. For example, average in Serbia we can offer 1 week treatment for all of these kids because it's increasing number and increasing prevalence of this disorder. So we contact Autism Speaking Association in New York, and we also contact WHO, and they have PCT, which is parental skill training, and it's very good training which we can offer to our parents, and that's the way how we can increase the intensive program for the kids. So this is kind of pyramid. You have the professional on the top, and then you educate the parents, and parents educate the parents. And these are the skills how to improve the condition of the children with neurodevelopmental disorder. Then we can have a crisis service models which include rapid evaluation and assessment services, like something that we can do in a couple days. And this is the use of emergency room and inpatient services by intervening immediately and providing intensive treatment. So these are kind of that was like hotlines, walk-in clinics, emergency room services, mobile crisis team, short-term residential services, home-based services. And this is something that we have for a child who are abused and neglect. So for all of them which are decide to take off from the family, we have these special crisis services which are settled within the social services, but they have a psychologist and they have us as a consultant to improve this kind of intervention which are needed at the beginning of the all kind of crisis. So this is something that just like therapeutic foster care is something that I think it's important just to a little bit talk about this, because these are for foster parents that are trained in the emotional and behavioral management of children and youth with severe emotional and behavioral problems, because we are all aware that putting children in another institution, it's not good for them. So that's the reason why we decide to educate more foster parents and to put this specifically abused children or children with severe problems within the foster homes. And settings usually are taking 1 or 2 children, of course, because it is difficult to have more of them. And it's good for children to have more attention. And then there are some randomized control studies that demonstrate improved behavior, decreased use of institutional care, and lowered cost compared if you put these children in the institution or in a psychiatric settings, which happened in the past. I don't know how it's in Turkey, but we have many kids with a child abuse and neglect issue putting in the psychiatric units, and they do not need to be there. They need to be apart from the abusers, but within some more open system than it's child psychiatry. And very important day treatment programs designed as more intensive option than traditional outpatient service. So the kids are coming, and I will show later our day hospital for adolescents. So they are staying for 8 hours, they have a full program, but they're going back home, and we can maybe make some deals with the schools, so half time in the hospital, half time in school, and this is something that is really improving their condition. On the other side, stigmatization, which is great issue among adolescents, is on that way lower. So frequently they are used as alternative to hospitalization for inpatient hospitalization. And although most studies of day treatment show positive results, most are uncontrollable, so we need more details how we can prove that these day treatment programs are very good. Telepsychiatry is something that is, I think, the last shift and the modern shift, and somehow, I don't know how you feel, but I sometimes feel that I'm lost in all this kind of technology that we are not using as we should use, because our kids, I read recently a paper from the Stanford University, they have a special team who analyze, and I was shocked with the data. So average child spend 5 hours and 15 minutes in front of the screens, whatever, phones, TV, whatever. And then if they are playing games on console, they're spending even 10 hours. So this is incredible. We don't know actually what these screens are making to our child. So what we should do is somehow use these instruments for our purpose. So I know, for example, then in Deutschland, in Germany, they start some kind of applications for depressed adolescents, how to improve their physical activities. And I know that there are many apps for autism spectrum kids. So somehow this is very sufficient to use this kind of telepsychiatry. And I don't know, are you aware of WHO program, which is now allowed to be on app on our mobile phones? They have MGAP programs, so you can have all kind of diagnostic and assessment procedure on different languages, on English for sure, they are now on Serbian and probably maybe they are on Turkish, so you can use this, I can maybe show you later, is excellent and easy way to, you know, to help you diagnostic and assessment tools. So this is something which could be very, very useful, and especially could use in rural and remote communities to gain access to psychiatric services and to support. So this will show to be highly satisfactory by the consumers, and we are not using telepsychiatry as we should do. This is my personal opinion. And I talk a little bit about this mental health liaison team already. So it's just the growing literature body that supports the importance of consultation and liaison in improving the efficacy of service delivery. There is evidence that psychiatric liaison teams are virtually not existent in the vast of the majority of the programs. I cannot imagine, like for the children who have diabetes or chronic renal disorder, or not to speak about the cancer patient and stuff. So it is absolutely crazy not to have the liaison team around them. So this is special. The pediatrician as a key point of care has been identified as an essential component of success, and we as a child and mental health professionals need to work in collaboration regarding this chronic illness. So this is just the break of the first part. So young men, this is my favorite journal, the New Yorker. So young men go to room and stay there until your cerebral cortex matures. So hopefully with the improving of the services, we will get these young men from the room and to help them get more and better life. So this is the family center community-based system of services, which we just talked. So we need to know that family with the children need to be in the center, and all other resource we need to use. Like, we didn't talk about spiritual resources. I don't know how it's in Turkey, but it is absolutely lacking in Serbia. And I think for some patients they will be very useful, like whatever you think about this. And then we have recreational programs. I saw yesterday in a Gold Hospital you have this recreational zone. Unfortunately, the clinic when I'm working, we have a park, but there is no place for recreation. We have actually a small fitness room within the institution, but for kids will be much better to have some out services. And for example, in Zagreb, in Croatia, they have a huge hospital for children and adolescent psychiatry, and within their hospital they have lovely park with all this recreational area, and we are all aware how this is important for our kids. So we need to have these resources, and there is many others like education, social services, medical home, insurance, transportation, juvenile justice. So this is something that all we need to collaborate and all we need to have within. So that's the reason why I think and believe that community-based system of services is something that will give the chance to our kids and adolescents to function better. So what works for families? Understand the individual family level. They need to understand the early stages of emotional problems. We need to help the family to understand how to access the mental health services. We need to provide the family with resources. We need to link the family with the family advocacy organization. We are lacking of that. I don't know, do you have family advocacy organization? But I was visiting in London, the Sunshine House for Early Developmental Disorder. They have a special professional who is the one who explains everything that bright medical doctor explain. You know, sometimes patients need to understand what's going on, and they have a special person who is actually the advocacy of, and I think this is very important. Also, we need to develop and build no wrong door policies, support the development of full area of effective mental health services. We need to support early identification and early intervention, and this is something that's absolutely lacking. And we also need to know and to educate patients how to do. And this is very good example, guidelines for health supervision of infant, children and adolescents, because it sets principles, strategies and tools that are theory-based, evidence-driven and system-oriented and can be used to improve health and well-being of all children, and within them, children with the mental health problems. And when we are speaking about primary health, task force on mental health theme, they need to facilitate health system changes, build clinician competencies and incrementally change practice, being a strong coalition. And I don't know how it's here, but our primary health care is completely overburdened with a caseload. For example, pediatrician in Serbia, they have around 30 to 60 patients per day. And then when we are asking them, could you please talk a little bit about the mental health issue, they are kind of, okay, come on. I cannot even ask for the name and what's the common problem, and you are now telling me to ask about mental health problems. But we did something. We developed on some developmental counseling services which can offer much more time to kids. So things can be done if the people have in mind that they need to assess some mental health problems. So we need to improve and to help pediatricians with strategies, how to work with the families, how to collaborate with the mental health professionals, educate the members of the chambers, because I found that the most problematic people to talk in collaborations are those who are highly level and highly educated, like professors of pediatricians, or even those who are in Republic Commission within the Ministry of Health. They cannot understand the need for collaboration, up to my opinion. So this is the paper that I want to show you. It was published in Lancet in 2017, and it says Architecture and Functioning of Children and Adolescent Mental Health Services in Europe. And it was characterized by the child and mental health services in the European Union in 28 countries. And there gives some common conclusion that neurodevelopmental disorders were the most frequent diagnostic group foreseen in child and adolescent mental health services, which is okay, we have a high prevalence, but I think we are not recognized enough other problems like depression, anxiety, behavioral problems, and that's the reason why we have this. Although I'm the one who is actually dealing mostly with autism spectrum disorder at my clinic, however, I know that this is not only the issue in child psychiatry, and although there are much more research in ADHD and bipolar and autism, we are lacking of services, treatment, guidelines, everything about other common mental health problems in children. This is also important to know that 70% of European Union countries have official child and adolescent mental health policy. For example, in Serbia we don't have, and I heard from Fosun you have. So you don't have or have? Okay, so we really need this. This is the way how we should actually prove that we are existing to our policymaker. So you can see here when we are speaking about a EU country, and this is the number of child and adolescent services per 100,000 population. As you can see, they have the biggest number of them are this is the Finland, I think, and then in UK and Ireland, in Germany, and in Slovenia. And then there is a less number in other countries of Europe. And then when you're speaking about inpatient beds per countries, you can see the largest number of beds are in Germany, following France, the Netherlands, and Switzerland, and the Czech Republic. Like last night, Professor Haberbarn told us that they have a huge number of beds, and all beds are full. For example, in Serbia, and now what is in Turkey, you will see the numbers, but we have, for the total population of 75, we have, let's say, 60 beds totally for 7.5 million people. And this is the proportion of young people treated in child and adolescent mental health services. As you can see, Italy is leading, and it's still 6.0% of children who has mental health problems are treated in the specific child and adolescent mental health services. And these are some very high-ranking countries like Denmark, or even, you see, the Netherlands and Poland, and still the numbers are really, really frightening how much care the children are getting. And also, when we are speaking about availability of the intervention in child and mental health services in your country, you can see that most of the countries are offering family psychoeducation, learning assistance, educational support, or speech or language training, cognitive behavior therapy, parental training guidance, and then we have other things. So this is something that is most valuable and probably most needed among our consumers. And this is also for the WHO, Therapeutic Intervention for Priority Mental Disorders of Children and Adolescents. And this is something that is, for me, should be discussed. So psychopharmacotherapy, it's something that is covered in almost all kind of problems in child adolescent functioning. And then we are lacking in the psychotherapy, and we are lacking in specialized intervention. So somehow most of our work is concentrated on psychopharmacotherapy, then CBT, and then family therapies. So somehow we maybe need to think how to improve other things. This is the paper that I just tell you recently about, which was published in 2018 in ECAP journal, and it speaks about the interface between child, adolescent, and adult mental health services. Again, result from the state research, so you can see estimated % of child and mental health service users with adult mental health services care needs as they age, and you can see that the majority of countries are actually lacking in this kind of transition, which is very much appreciated and needed when we are speaking about adolescent psychiatry. So the development of child-adolescent mental health services in absence of special national policy leads to fragmentation of the services, and that's the reason why we need a policy. Inefficient utilization of scarce resources, absolutely, that's true. Inability to provide effective advocacy for priority concerns. Like if we have a policy, if we have data to show why we need a policy, then we can go to politicians and make their decision to be on our side. If we have a lack of constituent participation in program development and inability to incorporate new knowledge in a systematic fashion, then we cannot improve the services provision for child-adolescent mental health. Okay, last part is I want to present what are the services in child adolescent psychiatry, and I'm cordially invited you to come to Serbia and to collaborate with us, because I think we can learn from each other and we can improve our collaboration. We are much more share in common than compare with Sweden or Denmark. I mean, we are all going and we are all looking for the UK, USA, Sweden, but somehow we have our resources, we have our ideas, so we have to find a way how to collaborate. So 50 to 25% of children, this is same, and the epidemiology is quite same all around the world. Children are same everywhere. So population in Serbia, as I told you, is around 7.1 million, and children are, let's say, I have better slide. The children is about 7% or even 18% of the population are children. Then when we are speaking about demography, you can see that usually from each year we have about 70%, like equal numbers of children of this 25%. And this is the good point, because I want to show you that our country is divided in several regions. And when we are speaking about services, we can have one in this part, one in this part, and one in this part, and that's all. So care is mostly provided in public sector in Serbia. We are now starting with more private sector, but it's not still well organized. Primary care is lacking in child-adolescent specialties, so we don't have none of child psychiatrists is working in pediatrician setting, which is very bad for our organization system. And most of the child psychiatry are in tertiary care centers, so the high-ranking professional level. And there is no nationwide studies concerning this issue. So what is the structure of organization of child adolescent health services? We have primary health care, and we have 34 developmental counseling services. So each town which have more than 8.5 thousand children needs to have counseling service for the children to 8 years. And then we have a youth counseling service. So numbers are not looking so bad, but unfortunately, only 9 of these services is working, and none of these services, even if they are existing, they are not working. Why? Because pediatricians, they do not have time to organize these kind of services within the primary health care. Then we have a secondary health care, which is hospital departments. Only one department in Serbia is within on the secondary health care, and it's settled in the main city, in Belgrade. And then we have tertiary health care clinics. So in primary care, children and adolescents, they can receive this kind of help, but even if they are good in numbers, even if they are very well organized, they are not working properly. The goal is preserving and improving health of adolescents, and through prevention and curative measures to do on health promotion, education, support, but still, even if they have very well developed plans and everything, actually, they are not doing their job. And the reason why they are not doing their job is overburden of pediatric issues they have. So, developmental counseling services, as I told you, only 9 has some kind of extra education and child-adolescent psychiatry issue, and only 2 specialists work in primary care setting. So these are these services. We have inpatient care provided in secondary tertiary care centers in some cities. So this is Belgrade, this is Novi Sad, Niš, and 40 number of beds per patients for 3 to 18 years. We have 52 beds in whole Serbia, and for adolescent 15 to 24, we have only 24. So 1 bed per almost 30,000 children in Serbia, 1 psychiatric bed. We have 2 daycare units for children and 3 daycare units for adolescents. So the capacity for the children is 33, only in larger city, again, Belgrade, Novi Sad and Niš. And then the total capacity in daycare units for adolescents is 48, so we have 3 daycare units for adolescents in Serbia. So this is the table, how we are organized. Unfortunately, you can see we have this blank, and this is only 111. So healthcare for children and adolescents is for free. Usually, most of the patients are referred by pediatrician, parents, Center for Social Work, schools, courts, and police. And the waiting list in public sector cannot overrun 30 days, which is, again, tremendous burden. So we are looking in UK. In UK, you are waiting for 8 months to be seen by child psychiatrists. In Serbia, you have to have in 30 days patients if they are referred from pediatrician, parents, and whatever. Somehow they have also, we call this emergency referral, then you need to do in 24 hours. And who cares if you have a job or you don't have, you need to take care about this patient. So these are the tertiary centers, mostly, as you can see, in Belgrade, the capital, and then 1 in Niš and in Novi Sad. And this is greetings from my colleagues from Niš. So he sent you greetings and invite you to come. So this is the clinic at the mental health for children at the Niš. It looks like yours, by the way, isn't it? A little bit. And this is clinic from the other side. So you can see they have inpatient upstairs, outpatient downstairs, and they have room for boys, room for girls. And this is something that he sent to you. This is Awareness Day in 2000, Clinical Center of Niš. So we are following this kind of globally procedure to aware people about neurodevelopmental disorder, especially autism. So this is Novi Sad. Again, we have an institution, a hospital with 10 beds. So they are mostly outpatient and daycare units. And the clinic where I work, we have 6 organizational units for children. We have inpatient department, which is with 20 beds. We have day hospital for children with a capacity of for 15 children. Then we have day hospital for adolescents in capacity of 30 adolescents. Outpatient department, which usually take into account per day about 50 patients. First referral, and then we have controls. And then we have the unit for the protection of children against abuse and neglect, and day hospital for substance abuse adolescent, which is community units, and these people are only working with adolescents above 18. So we don't have below 18. So overall capacity is, as I told you, 20. And we have 11 specialists, neuropsychiatrists, psychiatrists, and child adolescent psychiatrists. Only 3 of us child psychiatrists are working with all these patients, and then others are psychiatrists and neuropsychiatrists. So this is Institute of Mental Health. Please come and visit. This is in the city center, and this is our daycare hospital for children, which is so behind this building is a small garden, and this is building in the garden for the small kids. And this is our outpatient unit, so patients are first coming here. This is the waiting room, and then you have different ambulances for kids. This is our library at the adolescent unit, so they have a library, they have very good conditions to learn, to study, to have therapy, and this is one of the room for meetings and for the team assessment of the children. So this is our inpatient department, so they have some kind of occupational therapy. This is the crafts where our kids are made. So we have this kind of open door community treatment mobile teams, and we use this French model sectorial approach. Most of our colleagues were educated in Salpêtrière and Tavistock, so this is kind of, we try to be a community-based service. So, for example, again, our rooms. So this is a typical room for the child psychiatrist, like toys and computer. That's all we have, which is okay. This is our fish. We have small aquarium, so kids are coming so they can watch them. We found very relaxing actually to have aquarium in the waiting room, because when you are taking kids to the aquarium, they are looking for the fish, and they calm down a little bit before they came for assessing. So for example, the total of first referral in 2006 was 2,200, and up to the 15 years it was 1,200 and something. So the total control list is, as you can see, more than 11,000 per year. And as I told you, only 11 of us are working. So this is something that we are just planning to publish. So this is the first time I will present. It's what has been changed in 20 years in patient treatment for children and adolescents with mental health problems in our institution. So we have a database of 3,900 patients in period of 1996 to 2015, and patients are from 0 to 18. So in patients we have only adolescents till 18, and the problem is we on the same place have adolescent and small kids. They are separate in the different rooms, but still they are on the same place. And plus, for the children who are less than 8 years, they are with their parents at the department. So one parent and one child if the child is below 8. as you can see, what changed, we have increased number of pervasive and specific developmental disorders, and we have increased number in behavioral and emotional disorders, usually occurring in childhood and adolescent. So we have this kind of change in the time. As you can see here, there is a trend of increasing the number of this diagnosing within the year of admission. So you can see from 1996 to 1910 or even later, we have this kind of trend in increasing the number of patients. When we are speaking about what we are dealing the most is intersectorial cooperation with mental health services. So we are closely collaborate with my clinic with the pediatrician, preschool institutions, schools, Center for Social Work, facilities for deprived of parental care or facilities for children with disabilities, NGOs, whatever. Why I'm saying this is just because that it's not only the treatment and care we are giving to our children. Many of us are doing much more job than it's only treatment. Just briefly to introduce you education of child adolescent psychiatry, residency program is lasting 4 years and only 2 months in adult psychiatry, which we don't find very well, and only 2 lecturers in child psychiatry holding lectures in the 2 larger cities in Serbia. It's only 2 of us who are actually giving the education, which is a lot, it's a kind of burden for us. And now we have 42 specialists working with the children, among them 21 in child adolescent psychiatrists and 21 are psychiatrists working within child adolescent psychiatry departments. 21 of them are working in the tertiary health centers, you can see all of them, and 90 of them in secondary health care centers and only 2 in primary care. So this is the devastating number that only 1 specialist that works in child adolescent psychiatry stands for 47 and more thousand children and adolescents. At the end, what are the challenges? So services are mainly provided in the tertiary health care. Services are not uniform through the country. The prevention and improvement of mental health in children is marginalized. Pediatricians generally do not provide support. There are no forensic examination services for children. Even we have unit for child adolescent protection and from abuse and neglect, there is no forensic examination. Primary clinics that provide support and assistance are not included in the protection system, and there is a large number of, and still facing stigma and discrimination. So we have a lack of facilities, lack of human resources, we have a lack of financial resources, and stigma. So this is most common, again, with all of us working in child psychiatry. So what we need better organization with a special focus on prevention and improving primary care centers, formation and education of teams for mental health care in primary care, improved therapeutic potentials of primary care, because there are much more large number of pediatricians comparing with child psychiatry, and somehow we need to educate them more about this, and we need to improve existing clinical departments and to even open some more. So also, we are facing with them very much, like adult psychiatry are not happy with our child psychiatry program, but we need to preserve and to improve independency of child adolescent psychiatrists, to encourage candidates to choose child adolescent psychiatry. I heard yesterday that you know how many young residents in child psychiatry, which is very good because we need child psychiatrists. But in Serbia, people are not motivated because they cannot go easily to academic career, so you don't have the best, you know, that best wants to go to the academic career. So we need to somehow help this. And fortunately, we will have a board meeting next in Belgrade, and we will organize meeting with the stakeholders. So we'll try to improve this. So we need to enable better education and academic advancement for child adolescent specialties. So this is our association for child and adolescent psychiatry and allied professionals. And the goals of society is to raise the level of professional knowledge, to gather organization. And every 3 years we have a congress, and again, I'm cordially invited you. We will disseminate our invitation letter. We will send to Gul and to other colleagues from Turkey, so we'll be very happy to see you around and to exchange our knowledge. Something that we recently start is a regional cooperation. So we have a meeting of the presidency from Slovenia, Croatia, Macedonia, Bosnia and Herzegovina, and Serbia. And we learned something that in Bosnia is pretty much same situation. They have only 2 departments in child adolescent psychiatry and 6 specialists in child adolescent psychiatry. Then in Republic of Macedonia, they have 1 department for child adolescent psychiatry, 4 specialists that work in child psychiatry, 1 department in secondary care, and the training is lasting for 5 years. Then in Slovenia, they have 3 departments in country, 38 beds, 10 child adolescent psychiatry. They are very small countries, so you remember when I show you the previous slides, they have very good comparing with the number of the people they have. And in Croatia, they have a well-developed prevention program. They have patients come in secondary and tertiary centers, and the secondary care is most functional. About 20 child adolescent psychiatrists. We develop a team, and they hospital and polyclinics, so they have better organized. So somehow we realize that if you have better financial, that you have better structure political, then you have better child psychiatric services, and this is something that is common. And this is the end, so this is kind of how we regionally cooperate. We have a music, we have fun, so please come to Serbia, and we will love to have you around. Thank you very much.
Thank you very much for this excellent presentation. So we can have the questions from the audience. Sorusu olan var mı arkadaşlar?
Only 2 of them. If you have some question, we can maybe discuss.
I want to ask if in your country, when you discharge a patient from the inpatient service, how do you proceed the psychiatric follow-up?
We always say this, once you have your patient, you are married to the patient until the end, until they grow up till 18. So since you don't have any child psychiatry apart from the city centers, they are coming to the referral, they are coming to the outpatient to us again. So that's the reason why I have such a large number of controls. And until they get 18, after 18, you can send them, because there is much better developed psychiatry than child psychiatry in our country. So since they are 18, they can go and be seen by psychiatrists. So that's mostly what happened. And for the not so severe cases, we refer them to the school psychologist or psychologists or social workers working within the Center for Social Work. But all patients, especially those on medication, are coming again for visits after inpatient for months or even years. I have patients for 10 years now.
For 10 years. And one more question. Do you have opportunity to make electroconvulsive therapy?
To what kind of therapy?
ECT, electroconvulsive therapy?
No, it is not allowed to kids below 18, although we have only 1 center in Serbia which they can apply ECT, but it's only for adults. For children below 18, we are not applying ECT.
So, do you have opportunity to give clozapine to treatment-resistant cases?
Yes, we are giving a clozapine for those patients which we have protocols. But it's not national protocols. We invented protocols for institution where I'm working. So after 3 antipsychotic is not working, like 6 weeks, 6 weeks, 6 weeks, we are changing to the clozapine.
Okay, thank you very much.
You're welcome.